All right, so we are live. Good afternoon, everyone. Today is January 14th, Friday. This is Delaware Health and Community Updates from United Medical ACO. I'm here with Sean Donovan, and we are going to have a couple of guests joining us. This is our weekly event. We are trying to get these events on a weekly basis for our patients, for our employees, and for people who mainly live in Delaware. So, Sean, how are you doing?
I'm doing well today. How about yourself?
Good, good. So while we are getting ready, I'm going to make sure that I send these to our distribution groups, and let's open the session. All right, so we have different topics again. Mainly, we are going to make the updates, we'll give updates on COVID-19 numbers, vaccinations. This week is our clinical topic week, and chronic kidney failure is going to be our topic. And Donna Dunkel and Jennifer Fitzgerald is going to join us. They're going to join us from United Medical ACO and United Medical Clinic. And we have some updates from overall healthcare related fields, related topics, as long as we have time at the end. So, all right.
All right, yeah. So I'll start us off for today's session with one of our cartoons here. So this coming out recently, focusing on the healthcare workers and obviously the response, to the Omicron variant and just, the nation's response as a whole to, these record numbers. And I think this cartoon is very telling of the efforts and sacrifices that, a lot of our healthcare workers are having to make out there. Kind of just being that kingpin, chain link key factor in basically keeping everybody going, from care, testing, just as a whole, we're really relying really heavily on our healthcare workers, and we just want to, recognize and acknowledge the fact of, these efforts and strides that they're having to make to kind of just keep us, just above, because without them, obviously, we'd be in a lot deeper mess with the current pandemic and status.
Definitely, this is a really good description of the situation that's given and put on the healthcare workers, actually, offices, and some other stuff that we are going to discuss later on. But this actually really describes it very well. Thank you for bringing this. So we have our COVID update. So what do we have there?
Yep. So as I mentioned, we do have these record numbers. So looking at last week, we were at around 573,000 of our new cases. And then now the United States, we're looking at this current updated as of the 13th. The United States has that weekly average of 770,000. So, as we had mentioned in sessions earlier, even back in the end of 21, leading up to this new year with the holiday wave, we were kind of anticipating numbers to exponentially go up. I don't know if this is as high as we were initially thinking, but we definitely were expecting the new variants coming out, some record numbers. To what extent, like I said, I'm not sure if we're expecting almost 1 million. We're getting kind of up there, but with the new variant, there's definitely a lot of stress being put on our healthcare workers, and all of our team members trying to manage to the best of our ability in the most efficient way of some of these new record numbers that we're seeing. Mm-hmm. And then again, just another graph you see. And actually, it's kind of ironic. You see the two little humps from January of 21 and some of our previous sessions that used to be way higher up on the graph. But now, obviously, if you see these new record numbers, we had to zoom out. So it doesn't really actually look that big at all. But if you remember back to some of our previous sessions, that was 3/4 the way up the graph. But now, 200,000 seems like a measly number compared to the numbers we're seeing just this past week. And then our vaccination status, United States here, have 522 million doses so far. We're almost at 80%, enough to cover about 80% of the country's population. And as we always mention, we do have a steady uptrend on that visual down below. You do see it continuing to grow up. As we said, the booster is becoming available, and also with the pediatric population now being able to receive them. With this new variant too, we think that would encourage a lot more vaccinations. And then just number-wise, as you see here, we're over 208 million of our population being fully vaccinated. And with those boosters, just over 77 million is our current update. And then here, focus more on just Delaware, with our total vax over 575,000. This is steadily increasing. We did kind of plateau a little bit as we ended the year 2021, but now it is increasing again a little bit more faster than it did when it was tailing off at the end of 21.
So these numbers, we probably need to change our approach to these numbers. One of the main issues initially, what we were going through with unknown, and we took a lot of precautions and tried to protect everyone. And we did it in our offices. Personally, myself and my team, we put ourselves out there. My doctors, we were out there, and we are still doing the education of the COVID and the vaccination, the testing. So the problem is, I think the approach versus the actual severity of the problem, there is a little bit disproportioned, which is not being adjusted. So now what I would like to share is when we look at our Rollout numbers, so 2 days ago, our number of cases is 872,000.
Yep.
And then yesterday, this number was 806,000. And so far, this is kind of like, they try to go real time, but they didn't start feeding data yet. But it's going to be a high day. But if we look at these number of people reported with the number of deaths, that number is still very low compared to the total number of cases. So, and what we also know is many people are vaccinated, so the severity of the problem is a lot less. It's very mild. CDC changed the protocol on the quarantine time, so when people can come back to work, what the exposure is. But there's still some parties out there that are trying to put perception of if there was a extremely severe crisis there. So it's not the case. And I'm not trying to undermine what's happening. And in fact, I was one of the people who didn't undermine. In fact, I did the opposite for a long time. And what we see with the 872,000, there's only 2,000 people lost their lives. That's a miracle. But that also tells you that this is kind of like a flu-like problem that we are dealing with. And at some point, the approach and the perception need to change. So we are going to discuss those, but I don't want to make our guests wait too long. So I'm going to actually ask them to join us, Jennifer Fiscala and Donna Dunkel. Donna is our regular at these events. She loves us so much that she always wants to do this with us. And Jennifer is our physician assistant at United Medical Clinic. Hi, Jennifer.
Hello, thank you for having me.
Well, thank you for being with us. Jen, if you don't mind just introducing yourself, and then I'll ask the same thing to Donna after you.
Okay, so hi, my name is Jennifer Fiscala. I'm a certified physician assistant here at United Medical Clinic. I was born and raised in Delaware, been here my whole life, and I've been practicing for about the past, I'd say 4 or 5 months here at United Medical.
It's good to have you.
All right. My name is Donna Gunkel. I'm a nurse. I'm also the director of clinical integration here at United Medical ACO in the business office. So I oversee all of the clinical programs, our care coordination department, our nursing team, as well as our specialty programs, behavioral health, where we have social workers, and our dietitians. We have an accredited diabetes and nutrition program.
So for 2022, we are trying to make things a little bit different and trying to improve what we are doing. Every other week, we rotate between the clinical and billing-related topics. And this week is our clinical week. And we do want to share different chronic illnesses. And it doesn't have to be chronic necessarily, but the illnesses that we believe that public needs to know more about. And we started with depression. We started, first one was with the urinary problems in elderly population. And today we are going to discuss the chronic kidney failure. So Jennifer actually prepped this for us. So I'm going to actually let her speak. Before I let her do that, I do want to make sure our patients do understand United Medical ACO is a clinically integrated organization. There are several practices. Our nurses do provide care for many of these practices altogether. There are many different programs in place, and we do daily case conferences, and we try to follow up on patients from their primary care visits to their specialty visits, and anything that they may need. Some patients need more care than the others, and that's where we come into the picture, and then we try to support them more. And these events are kind of extension to those activities so that we can actually give more support to our patients. So before I make this too long, so I'm going to let Jennifer take over from here.
Thank you. So today we'll be talking about chronic kidney failure. So to start it off, I wanted to first talk about chronic kidney disease because there are various stages before you reach, the fifth and final stage of chronic kidney failure. So to kind of give a brief introduction to all of chronic kidney disease, the main thing that we look at as providers is the staging of chronic kidney disease. And what essentially makes up the staging criteria is what we call the GFR, which is the glomerular filtration rate, which has to do with the rate at which these structures that we have in our kidneys, glomeruli, are filtering out waste and extra fluids that we have in our bloodstream. One of the main things to pay attention to when we talk about chronic kidney disease in these stages, generally patients will say, what symptoms should I be looking out for? The thing with chronic kidney disease and, eventually kidney failure is that oftentimes it's asymptomatic until a thing that we call uremia sets in, which often does not take place until we reach stage 5, which is kidney failure. With that being said, there are a few other symptoms that can take place, such as nausea, vomiting, weight loss, decrease in appetite, fluid retention, high blood pressure. But unfortunately, those are, what we consider to be nonspecific symptoms. So essentially, what's key for us as providers is to make sure we're doing, routine blood work when it's necessary and at least on a yearly basis, because, as the previous slide explains, it's essentially a relatively asymptomatic disease, especially at the onset. So in regards to how we treat chronic kidney failure, from the primary care provider side, the biggest thing for us to pay attention to is to know these beginning warning signs and symptoms, especially pertaining to when we receive the results of, annual blood work, and make sure that we're prompt in referring patients to nephrologists, the specialists. And overall, the main goal is to help prevent progression of this disease. Also, in addition to referring, we don't like to just hand off patients. Our role then becomes treating underlying causes of chronic kidney disease. So some underlying causes are hypertension, diabetes mellitus, high salt and protein intakes, high potassium intakes, and then there's also a wide variety of medications that we consider nephrotoxic, meaning they can do damage to the kidneys. And as I stated before, the focus really from the family medicine aspect is to slow the progression to kidney failure. We don't want patients to, rapidly reach stage 5, and we try to do everything we can to slow that rate down. As you can see here, there's some statistics, and they're not too great. 5-year survival of kidney transplant recipients is between 37 to 54%. And those who receive dialysis only have an average life expectancy of 3 to 5 years. And unfortunately, if a patient is at stage 5, which is considered kidney failure, and no transplant or dialysis is done, progressive uremia will take place, meaning, rapidly waste will build up in the bloodstream and ultimately leads to patient death. And then over to the right there, that was just kind of a stepwise guided approach for primary care providers to kind of take into consideration of, looking at when you receive those lab results and you say, okay, my patient has a GFR at this value, what stage are we in? It kind of gives a generalized idea of, how aggressive we need to be in making sure we're looking at the correct parameters and making sure that that patient has routine follow-up with their specialist.
So Jen, we, in our case conferences, a lot of patients that we see who are not being treated, they're in this group. Donna, correct me if I'm wrong, but when we look at the lab results, a lot of patients are in this group. And then that's where we actually sometimes send messages to the providers.
Stage 3, correct, yes. And to Jen's point, the key there is to make sure that the patients get the routine follow-up. So one of the other things that we do when we're in our case conference, and I'm sure the providers do as well, is making sure before that patient leaves the office that they have their next follow-up appointment scheduled, so that they don't go too long in between. And should some complication arise, it can be taken care of more quickly.
Okay, and speaking of complications, there are several complications of not only chronic kidney failure, but also in those stages, such as, once we start getting into stage 3, moderate kidney disease, we can see these complications as well. So you can have disorders of the metabolism of minerals. So it can lead to what we call renal osteodystrophy, which actually what ends up happening is there's actually a structural alteration of the bones in these patients. There's also something called anemia of chronic disease. It's a specific subset of an anemia, and that has to do with low EPO, which is erythropoietin production. And in terms of the way our blood is working overall, unfortunately, it can lead to coagulopathies because the platelets are not working properly anymore. The body just becomes in such a high level of stress. And then you can get hyperkalemia as well, which has its own set of signs and symptoms that, just cascade and cause their own problems, such as arrhythmias. And then hypertension, which an interesting point, it is both a cause and a complication of chronic kidney disease. So this is something that we see in a wide variety of our patients with chronic kidney disease. It almost goes hand in hand that hypertension is a comorbidity. And overall, I wanted to do a slide on kind of my view of COVID-19 and patients that are affected by chronic kidney disease and kidney failure. What I've seen just in my short time of being a primary care provider is that several patients are delaying their routine follow-up or active treatments because they still have that fear of leaving the home, and they almost feel safer, not actively treating their chronic kidney disease out of concern of, catching COVID. There's also a well-known fact is there's been an increase in poor diet since the beginning of this pandemic. There's a lot of times been a decrease in exercise as well, and just getting out of the home and moving around, which just further increases the chance of, getting these risk factors for chronic kidney failure. And also, a big point is that a lot of patients I've noticed are coming back to me and saying that they haven't seen their nephrologist, specifically because some specialists still to this date are really only doing telemedicine for the most part. And unfortunately, a high population that we see of patients with chronic kidney disease and kidney failure are the geriatric patient. So either, they're just not open to telemedicine, or they don't know how to utilize it. So instead, they keep pushing back their follow-up appointments. And in the meantime, medications are running out and their levels aren't being monitored.
So I believe that was our last slide, if I'm not mistaken. So the issue, there are a couple of things that are extremely important for us. One is this delaying the care, especially with the COVID. And although there's a perception with elderly population not utilizing telemedicine, we did prove that wrong at United Medical Clinic and in our surgical practice at CRIAS. So we are actually seeing patients through telemedicine, and we ask them when they need to come in. We do make sure that they are able to come in, but it's about safety issue in those cases. But in many cases, we are able to provide what they need through a video visit. In fact, like this morning, you and I and Donna, we were in a case conference, and there were some follow-ups that we needed to do. And those patients, for them to wait, again, there was another patient after our case conference, we had the bariatric at 10. There was a patient with A1C 15.2, and that patient didn't make an appointment with the endocrinologist. So, I mean, it's not the kidney failure, but it's a similar severity in terms of what can happen to a patient. So, and some people really, they don't understand how serious these problems can be. But you're in your office, you're available, you're providing care, you're providing excellent care. More importantly, you are here to actually provide this session for our patients. So we are hoping that we can actually reach out to more people and then educate more, make more people aware of what we have in place. So that's kind of our goal. So Donna, anything you would like to add?
Just two quick things. One is, yes, we don't want to see the delay in care. So on the front end, when we're calling our patients, is making sure that we relay that information to them and encourage them to get a family member or someone else to help them with the technology, if that's the issue, for telehealth. So that's a big key component of that. And then I just wanted to say, and follow up to what Kemal said earlier, every 2 weeks we are discussing clinical aspects. So in 2 weeks, on the 28th, we will have Dr. Barnett Smith talking to us about hypertension. So that goes hand in hand with what Jen was just talking about. And then later in February, we'll be talking about COPD, sleep apnea, weight loss. And then in March, we move on to talk about diabetes. So a lot of good topics coming up. I just wanted to let everyone know what some of them are.
That's excellent. Thank you, Donna. And I know you are also putting a lot of time and effort for these. And in fact, like last Wednesday night, we did our diabetes session for Wednesday wellness webinar. And these things do take time, but I do know that they are reaching out to some people. And Buddy is agreeing with us, so he's on the back. Hey, Buddy. Well, Jen, thank you again for taking time from your clinical hours. So I'm sure we'll ask you to join us again. Donna, thank you. So we have some other items that we are going to continue with Sean. Thank you, guys.
Thank
Thank you
you.
for having me. Take care.
Bye-bye.
All right, Sean, we are back to our other items. So one of the updates that we have is the mask mandate, which is, I'm a big fan of using the mask when it's necessary, but this mask mandate is universal indoor, which means
Right.
when you are playing tennis indoor, you have to put your mask on. So for 90 minutes, having that mask on, it's just trying to, almost like trying to kill yourself in a different way. You can breathe, like it's just, okay, I'll tell you why I'm a little bit upset about this.
Sure.
It's because I try so hard to go through all the precautions, take my vaccine on time, and keep social distance. Not only social distance, I kept myself out of social events for all this time, but now we have to go back to this because this is it is at the point where it is right now, and that's not right. So we shouldn't be penalized for those who are not vaccinated. I'm going to say just the way it is. So people should be vaccinated. It doesn't have to be mandated. I'm not saying that it should be, but now everyone is paying for it. And like my parents are going to go back tomorrow, 10-hour flight. They have to keep the mask on. It's almost so inhumane.
Right.
So just because people don't want to take accountability, and that's not right.
Mm-hmm. Yeah. As you said, we really like the severity too. It seems almost like we're going back to where we started, as if we didn't learn from the initial. And like you're saying, the different lifestyle things. Like you're saying, tennis, or even now when I go back to the gym at night, you see everyone in there working out, and it's hard to do some of these activities. Like you're saying, even the flight with the mask, or exert yourself, because they look at the people at the gym trying to take care of their health, get better, and now it's more difficult.
But I do want to cover our book topic today, just because it's a good. This actually is a really good one. All the books are good, but this is one of my favorites. So you had time to read it, right? So you finished it from last week. I know you did.
Well, I thought I was going to read the book to everyone right now. Have enough time. But so this week we had the 7 Habits of Highly Effective People as our current feature. So
this is by Stephen Covey, and now initially you may see this book as like a business book, but as I was explaining earlier when you and I were talking, this is not just a business book. This is a book of life. So you can choose to do certain things in a certain way, and this actually does help you to see certain things. So the first one is be proactive. So many people are failing with this